Hello everyone. Recently, I was attending on our medicine consult service, supervising 2 new interns, and I was trying to explain to them what makes for an effective consultant. And I realized that the job can really be reduced down to a discrete list of easily identifiable actions. Today, I'm going to run through 10 tips on how to become an effective consultant, and keep in mind that these are most applicable at academic medical centers with trainees. In private community hospitals, consultants often play the role of co-manager, where it's expected that they will completely take over the management of those problems for which they are consulted. But at academic centers, there will be a primary team that will ultimately be responsible for the patient's care, and the primary team may call any one of 24 consulting services. When requested, a consulting team will interview and examine the patient, review the chart and other data, and then provide recommendations, or recs, back to the primary team. It's up to the primary team to synthesize all the recommendations from various consulting services into a coherent plan for the patient. For all of this to happen efficiently and without mistakes, clear and timely communication is of key importance. So on to my 10 tips on how to become an effective inpatient consultant. First, determine the specific consult question or questions, but accept that it's okay if there isn't one. There are 2 reasons to try to pin down the primary team to specific questions. First, you want to be sure that you are providing the service that's being requested. After all, if you're on infectious disease and you give a recommendation about antibiotic selection, but the primary team only needed help deciding antibiotic duration, you actually haven't been helpful. The second reason is to make sure that you are the right person to be doing the consulting in the first place. For example, if you're on podiatry consult and someone consults you to see a diabetic patient with a severe foot infection, you might not question it. But if you learn later that the consult question is not about diagnosis or wound management, but rather, how can we improve vascular flow to the foot? Well, that consult question would be best redirected to the vascular surgery service instead. So always try to figure out the question. However, sometimes there may not be a question, and that's okay. If a patient is admitted to the ENT service, for example, for refractory epistaxis, but is noted to concurrently have end-stage heart failure and metastatic lung cancer, it's perfectly fine for the ENT team to call a medicine consult with a simple request to help make sure those problems are being managed appropriately. Realize that if someone is asking for your opinion, it's usually because they, or sometimes they're attending, doesn't feel comfortable managing that problem on their own. So don't give them a hard time, just give them help. Number 2, and this one's simple. Indicate how long it will take you to see the patient and provide recs. You don't need to predict a precise time to the minute, but let the primary team know if it will be this afternoon or the next morning. Next, when introducing yourself to the patient, clearly identify yourself as a consultant and explain that role. On MedConsult, I'll usually say something like, "Hi, my name is Eric Strong and I'm an internist. I've been asked by your psychiatrist to speak with you and examine you today because they would like my help to make sure that your high blood pressure is being taken care of while you receive treatment for your depression." The goal here is to make sure the patient knows your role is limited. You're not there to determine a discharge date, hold family meetings, or discuss any one of a dozen other issues. You're there for a specific reason. You're not being rude or dismissive to limit the scope of your patient encounter to the consult questions, but rather you are grounding expectations of the service you're there to provide, and you're preventing the too many cooks in the kitchen phenomenon that happens when consultants stray outside their intended role. Along that line, as the consultant, you should avoid discussing dramatic changes to management without first conferring with the primary team. Remember that only the primary team has the complete picture of the patient's status and plan. As a general surgeon, you may think the patient should have their colon cancer resected and are eager to consent the patient for that. But maybe unbeknownst to you, the oncologist has found that the cancer is metastatic and the patient's life expectancy is too short to justify surgery. Or maybe the psychiatrist has determined that the patient's schizophrenia is severe enough to prevent the patient from having capacity to consent to the procedure. Always confer with the primary team before discussing big things with the patient. This includes estimating discharge dates. As a hospitalist, I will attest to the damage that can be done to the doctor-patient relationship when a consultant tells a patient he or she can go home, only for the primary team to come along an hour later and rescind that decision based on something of which the consultant was unaware. After the initial visit with the patient, you should try to give the first set of recs directly to the primary team face-to-face. If this isn't possible, then do it over the phone. Never allow a note left in the chart to serve as the only means of communicating initial recs to the primary team. You want to establish some type of interpersonal connection between yourself and the primary service. This helps to make sure the primary team understands and follows your recs and will help you to be sure you're answering the right questions. It's also good practice to meet the other doctors taking care of the same patient just in general. I actually think patients would be amazed at how often the various doctors seeing them over the course of the day don't even know what each other look like, let alone have an effective professional relationship. Having said that, however, also be sure to leave a note in the chart as soon as possible. Remember that it's not just the primary team who's interested in what you have to say, but also other consulting services, nursing, and case management, among others. Also, the primary team may not have caught everything you said in person, particularly if there are many recs, or if the recs cover complex issues well outside their typical practice. When you give recs, be sure the list is succinct and clear, and that they address the primary question or questions. As a general rule of thumb, put the discussion of your thought process in one section of the note, and leave the recs or action items in a distinct section. Try to give no more than 3 recs each day, and try to reduce each one to 1 to 2 sentences in length. I've found that when recs start to number more than 3, the likelihood of the primary team following all of them starts to drop off. It seems crazy, but doctors are busy people with limited attention spans. They don't have time to sort through a dozen different suggestions, each with a discussion of a differential diagnosis, complete with references to the primary literature. I've actually known some doctors to place the list of recs at the very top of the note in order to maximize the chance that each one is followed. It's okay to comment on additional issues for which you are not specifically asked about, but avoid commenting too specifically on any issue that falls well outside your area of expertise. For example, suppose you are on the cardiology consult service. The inpatient medicine team asks for your help managing heart failure, but while you are evaluating the patient, you notice that he or she is not on anticoagulation for the atrial fibrillation. It's perfectly fine to give specific recommendations about this. But if you also notice that his or her diabetes is out of control, please do not recommend a detailed insulin regimen. Instead, if you're really concerned about the diabetes, it's much preferable to say something like, "We recommend improved diabetes control to minimize risk of heart disease." It's borderline insulting for a consult service to give a primary team specific advice about a problem with which the primary team is presumably more knowledgeable. If the primary team chooses to not follow a recommendation, attempt to determine why they are not doing so, but do this in a respectful and non-judgmental fashion. There are a couple of reasons for this. First, you want to be sure they saw and understood your recommendation. Second, you want to find out if the primary team is basing this decision on additional data of which you're not aware. Finally, maybe the primary team's explanation for not following your recommendation is actually a really good one and might make you reconsider your own recommendation. The bottom line is that it's okay for a primary team to not follow a consultant's rec, but they should always be able to explain why they aren't. And sometimes the consultant will learn something from this explanation. And finally, the last tip, always end each consult note with one of the following lines. We will continue to follow daily. We will continue to follow peripherally, which will be interpreted to mean we're not going to be seeing the patient every day, so if something urgent happens, let us know. Or we will sign off at this time. Please call if new questions come up. You should never leave the primary team in the dark as to whether or not you're still following a patient. one of the worst things a consultant can do is to stop seeing a patient and not let the primary team know this. The primary team may be counting on your daily assessment of an important and evolving problem and may not realize they need to recontact you if something dramatic changes that requires additional intervention. So that's it. Those are my 10 tips on how to become an effective inpatient consultant. Feel free to leave questions, comments, and your own ideas below.